let Dr. Baines begin.
All right, everyone. It is 7 o'clock. So thank you to everyone for hopping on, and thank you to Dr. Jen Rubin for accepting our invitation to speak today for our neurosciences grand rounds. We're incredibly grateful for her time and expertise. Dr. Rubin completed college at Indiana University and then went on to complete medical school at the University of Louisville. She completed her pediatrics residency and then child neurology fellowship through Children's Memorial Hospital in Chicago. From there on, she gained knowledge and expertise in neuroimmunology through spending time rotating with neuroimmunologists at Northwestern. Um, since then, she has gone on to lead and contribute to many publications, most recently this year on brain and spine MRI characteristics of a pediatric cohort with MOGAD. She is involved in a number of studies, both involving multiple sclerosis as well as clinical trials involving leukodystrophies. She serves as an associate professor of pediatrics at the Northwestern University Feinberg School of Medicine and is the director of the Pediatric Demyelinating Disease Clinic and director of the Leukodystrophy Multidisciplinary Care Program. And I feel like that's only skimming the surface. So thank you again, Dr. Rubin. I'll let you carry on.
Hello, morning, everybody. You can hear me okay?
Yes, we can.
Perfect. So, I am most impressed that you guys have a grand rounds at 7 a.m. It's 9 a.m. here in Chicago. And I'm secondly impressed that you start on time. This is a great example for people. It reinforces people to get there. So, hello, good morning, everybody. So, like she said, I'm the director of the leukodystrophy program here at Lurie. So, I'm going to talk about leukodystrophies and then kind of give a overview of them, and then talk about some advances in pre-symptomatic diagnosis and treatment that has mostly come about because of newborn screening. So we'll talk a little bit about newborn screening as well. And hopefully we'll have time at the end for questions. So I have no relevant disclosures in the last several years, although in the past I've consulted for Krabbe disease and metachromatic leukodystrophy. And like she said, we have a Canavan disease clinical trial that's open at Lurie's. So I am hopeful that by the end of this, we'll be able to describe some signs and symptoms to suggest leukodystrophies, to analyze newborn screening results to help guide evaluation and management, and then to help manage infants, children, and teens with leukodystrophy, including supportive care and palliative care. So just to kind of start off with an introduction. So about 10 years ago, Dr. Vanderver at CHOP and colleagues decided that they needed to have a case definition and classification of leukodystrophies. So the number of leukodystrophies is small. Each of these conditions is rare. And this lack of a precise classification makes kind of epidemiologic and incident assessments difficult. And so they decided to kind of come together and make a definition of what would qualify as a leukodystrophy. The other nice thing about this is it can be applied prospectively. So if new conditions are discovered, particularly hypomyelinating disorders, they can use this case definition to add leukodystrophies to the diagnosis. So what they decided was that and some of these things we do seem pretty straightforward, but it's nice to kind of all start together with a case definition. So leukodystrophies are heritable disorders affecting the white matter of the central nervous system with or without peripheral nervous system involvement. And what these disorders have in common is that they affect the glial cell or the myelin sheath. So as you can see, there's an oligodendrocyte there that is providing its tentacles to have the myelin sheath. And the other thing that this does is provide nutrients and support for the myelin. The published incidence is about 1 in 4,700 live births. So what they also clarified in this paper is that leukodystrophies fall in two broad categories. There's hypomyelinating disorders and then dysmyelinating or demyelinating disorders. And in this paper, they sort of decided that this dysmyelinating, demyelinating were not two separate entities. They're just going to all be sort of the same thing. And hypomyelinating disorders are disorders of myelin production. Um, and an example of that is Pelizaeus-Merzbacher disease. And the dysmyelinating or demyelinating diseases have myelin destruction. And we will talk about some of these conditions today. And then the other important thing they did was to say, we know that there are lots of conditions that can affect the white matter, and we're going to call those kind of genetic leukoencephalopathies. So these are disorders that can have significant white matter abnormalities, but do not meet criteria for inclusion as a leukodystrophy. Either they have primary neuronal involvement or prominent systemic manifestations that kind of overshadow these white matter abnormalities. So mitochondrial diseases can be an example of these. Zellweger spectrum disorder. So when we do newborn screening for X-linked ALD, we find Zellweger spectrum disorder, which can have prominent white matter disease, but they have prominent systemic manifestations, including liver disease. So that was not included as like a pure leukodystrophy. So this is like an exhaustive list at the time of leukodystrophies. And so you can see we're not going to cover all these conditions today. And then it's important to note that some of these disorders met 100% consensus for classification after the first survey round, things like Canavan disease and Krabbe disease. But some of these other ones, like Aicardi-Goutieres syndrome, took a little more thought about whether or not they should be classified as a leukodystrophy. So how do these conditions present? When should we think about them? So, in contrast to gray matter conditions, which have seizures and mental and kind of cognitive changes, typically with leukodystrophies, the first thing you see is motor changes. So hypomyelinating disorders typically have motor delay, and then leukodystrophies with myelin destruction can have kind of stagnation and then regression. You can have other motor symptoms, new clumsiness, more frequent falls. Toe walking is a big one in toddlers and young kids. Some of the findings are pretty specific for specific leukodystrophies. So like acute deterioration after illness or minor head trauma should make people think about vanishing white matter disease. And then with some of the other ones, you can have cerebellar volume loss, ataxia, and it's common but not required to have a peripheral neuropathy with some of these conditions. And then as the disease progresses, you can have abnormal tone. Sometimes these kids have truncal hypotonia and appendicular spasticity. You can have increased difficulty or lose the ability to walk, trouble with speech and swallowing, decline in hearing and vision, and then kind of overall decline in development. The other important thing about these leukodystrophies is sometimes you need to take a really long view. So, we have learned over time that kids with cerebral palsy, not all of them have cerebral palsy, and some of them, for example, if they have dystonia, they may have an underlying genetic condition. The same is true for some of these kids with motor symptoms. So, we need to take a long view, and if there has been decline over years, it may be that there's instead a hypomyelinating leukodystrophy. And I'm just going to speak briefly about adult onset leukodystrophies. I think we don't think about these enough. In general, there's a milder kind of stuttering course with a wider phenotype. And you'll see as I talk about some of these more specific leukodystrophies today, there is, they're in general, the earlier they present, the more severe they are and the quicker they progress. So in adult onset leukodystrophies, it can be pretty insidious. But you do often see more neuropsychiatric and behavior symptoms that can precede the motor symptoms by years. And because these features are nonspecific and subtle, they can be missed. And the other kind of diagnostic challenge is that a lot more adults have nonspecific white matter changes. So you can imagine these are missed in, stroke clinics or multiple sclerosis clinics where you may see white matter changes that are attributed to other causes. This paper, all at the end, there's some reference sections at the end. This paper is really lovely. It's an adult onset leukodystrophy kind of guide for evaluation. Parenthetically, I also think it's a lot harder for our adult colleagues to get genetic testing, and it's a little less easy to get it approved and everything. So I think these conditions are missed. Okay, so how are I'm going to kind of give a general overview of evaluation and diagnosis of leukodystrophies. So in general, when you suspect a leukodystrophy, the place to start is an MRI brain with and without contrast. And then we'll talk a little bit about in pediatrics, like typical myelination patterns. And then what you want to do is assess the pattern of involvement. Is it confluent? Is it multifocal? If it's confluent, what the prominent location is. And then exclude mimics like infection or demyelinating conditions. And then the age, the presenting symptoms, and the biological sex help guide diagnostic management. I had included one of these super fancy, complicated slides about, if it's multifocal, here's what you look for. But, I think that all of those things are lovely and it's academically very interesting. I think now with genetic testing, I think it's a little less important to overanalyze the pattern of involvement and kind of cast a little bit broader net. So, as far as abnormal myelination, you need to review the images based on age-appropriate myelination patterns. We see in younger kids a lot of delayed myelination where there's kind of nonspecific T2 flare hyperintensities around the periventricular area. It can be helpful to repeat an MRI scan at least 6 months later to see if it is delayed or it's abnormal. And kind of two kind of characteristics of hypomyelination are that if you do two MRIs at least 6 months apart, if there's no advancement of myelination or no kind of if it still stays the same, or if you have a kid that's over 2 that has significant delays in myelination, it's probably instead hypomyelinating disorder. And then, even with our best efforts, we will find that there is a subset of kids that we don't have a diagnosis. In those particular cases, it's helpful at some point in their diagnostic odyssey to get a spine MRI scan because some of the conditions have spine involvement, and that may be a clue to the leukodystrophy. So this is can you see my pointer as I'm sharing the screen?
Yes, we can.
Oh, yay. Perfect. So this is Dr. Vandernap. She is in the Netherlands and she can literally look at any MRI scan and tell you exactly what the child has. But this was an invited article based on an MRI approach to the diagnosis of white matter conditions. And so this is really important. This shows normal myelination. So this is the top is the T2 sequences and the bottom is the T1, and A and E are newborns and D and H are 5-year-olds. And so this shows the progression of typical myelination. And what we notice is a couple of things. Oops. One is that the baby brain is not myelinated and is very watery. And so there's a lot of T2 flare hyperintensity from the typical brain. And then over time, in a certain sequence of myelination, you have the typical dark appearance that we think of on T2 images, where the white matter is dark and the gray matter is brighter. What the important thing to note is first that the baby brain looks different. Number two is that there's a sequence of typical myelination that evolves over time. And the other thing, which I think is really helpful, is that the T1 image always looks better, always looks more myelinated for age than the T2. So I think T1 images are helpful to kind of assess the progression of myelination because they're easier to see and they typically look more advanced and better compared to the T2 images. So this kind of serves as just an important reminder of how things look over time. And then to differentiate hypomyelinating disorders versus dysmyelinating disorders. So we talked about normal myelin is bright. Um, um, Normal myelin is bright on a T1 image and dark on a T2 image. And so this is a kid on this side is a dysmyelinating condition. So this is a kid with metachromatic leukodystrophy where it's bright on T2. So this is abnormal myelin. And then you can see that it's dark on T1. Um, the In contrast, the hypomyelinating disorders are more subtle and they show diffuse T2. This is a kid with Palazius-Merzbacher, and they show brightness, but not as bright. And then on T1 image, it can be iso intense or a little hyper intense. So that is one way to differentiate hypomyelinating versus dysmyelinating disorders. Okay, so when we have kids who we suspect a leukodystrophy, we think about sending biochemical and enzymatic testing and genetic testing. I think the default nowadays is to send a lot of genetic testing, which is absolutely lovely. There's a couple reasons why I think biochemical testing is still so critical. Number one is it's just way faster. So, we can get some of these biochemical test results in a week versus a month or 3 months for next gen sequencing. The other thing is that we've had early on some of the we've suspected leukodystrophies, and those panels aren't necessarily exhaustive, so we have had kids who we've missed things on that had genetic leukoencephalopathies, um, who were missed on some of these panels. And then the third thing, which is what I think is the kind of scariest, is we've had kids who've had unremarkable whole exome sequences who've had leukodystrophies. So, I'm thinking of a kid in particular that came for an opinion for metachromatic leukodystrophy. The age was right, the scans were right, and they had a whole exome that was negative. And then we did biochemical testing, and that's what they had. And then we reached back out to the company who looked at the raw data, and they did not report out one of the pathogenic variants, which is like super scary. So I think that it is important to think about biochemical testing in addition to genetic testing. And this is kind of a summary of what we send. We send the lysosomal enzyme panel. If you have a high suspicion for metachromatic leukodystrophy, you should send the urine sulfatides with that because that's the confirmatory test. And then, looking for some other genetic leukoencephalopathies like organic acidemias and amino acid disorders. And then cholestanol looks for CTX. So this is kind of and obviously what the patient presents with. If it's a very classic disorder, we have a more narrow differential. If you suspect kind of a hypomyelinating disorder, or a classic leukodystrophy, I think a leukodystrophy panel is fine. But if they have any systemic concerns, any dysmorphic features, I really think next gen sequencing, like whole exome sequencing, is the way to go. With the caveat that it takes some time. So if people have potentially treatable leukodystrophies, that's why this biochemical testing is so important. And sometimes you can send a panel, get these biochemical tests back, and then if it's pointing to a more specific disorder, you can change your testing to a faster gene testing. We have also had patients who we've only found one and have a presumed autosomal recessive condition who we've only found one variant. And we also have the ability to kind of reanalyze it or run it, kind of look at that one gene to see if there's other variants. Okay, so the other big category of ways people are diagnosed with leukodystrophies is on newborn screening. So I'm going to spend a little bit of time talking about newborn screening. So There are three leukodystrophies that are on the new are potentially identifiable via newborn screening. One is Krabbe disease, one is X-linked ALD, and the other is MLD. Right now, I do not think there's any states screening for MLD. Illinois was the first state last year to pass legislation to start screening for MLD. It will surprise no one if you know anything about Illinois politics and government that it is not yet up and running. There's a lot of regulatory hoops to jump through. And so New York, Pennsylvania, and Minnesota have also passed legislation to start screening for MLD, and I suspect they will beat Illinois if they haven't already. Um, it's important to note that these newborn screenings vary from state to state. So if you practice somewhere where you see people from other areas, they may have different things on their newborn screening. Um, I looked, and you guys can correct me if I'm wrong, but it looks like Arizona has only X-linked ALD. Krabbe disease and X-linked ALD are on the RUSP or on the recommended uniform screening panel. Krabbe disease was only added in the last year. And so we'll look at the next slide. A lot of states have legislation in place that once something is added to the RUSP, they're supposed to be RUSP aligned. That being said, there is also a lot of politics around Health and Human Services and RUSP and things not people these committees not being funded and whatnot. So I don't know if all of these things are going to be enforceable and able to be rolled out. Oh, I'll show you later when I look at the Krabbe disease. Okay, so we'll look at that later. So let's talk about some common leukodystrophies and their treatment. So I'm going to talk about Krabbe disease, metachromatic leukodystrophy, and X-linked ALD. And the reason I'm focusing on those is because there's treatments and because we're screening pre-symptomatic individuals. But things are changing quickly, and this is an exciting time for this space. So, Krabbe disease is an autosomal recessive condition of lipid storage caused by a deficiency in the galactoserbrosidase enzyme, and it breaks down some sphingolipids, and they have accumulation of these that results in damage or demyelination. And then, because of this, these characteristic globoid cells appear in the affected areas of the brain, and that's why it's also called globoid cell leukodystrophy. We will talk a little bit about newborn screening, but in general, just as I mentioned before, there are earlier onsets and later onset of conditions. The earlier onset forms tend to progress more rapidly. So the most common and catastrophic presentation of Krabbe disease is early infantile, is early infantile. And those children present, typically they're developing normally at birth, and then around 3 months of age, have fussiness, arching, irritability. They can initially be misdiagnosed as reflux. And then they start to have more feeding difficulties, failure to thrive, a lot of oral pharyngeal dysphagia. And then they have, continued developmental arrest and regression and spasticity. One case I took care of, the mom, you get about a 3-month maternity leave, and the mom, the last time she ever saw the baby smile was the day before she went back to work, and the baby was subsequently diagnosed with Krabbe disease. The diagnostic features are low Gal-C activity and elevated cytosine. They can have white matter abnormalities. Think about what we talked about the newborn brain and how there's some T2 hyperintensity at baseline there. So some of these can be really subtle. And I've seen kids whose MRI scans have been read as normal early on, just because it's subtle and it's hard to tell. They often have elevated CSF, or they always have elevated CSF protein, and then these are rapidly progressive within the first year of life. Once patients have symptoms, they are not eligible for any therapies or any curative therapies. So the only way to treat these children is pre-symptomatic diagnosis and stem cell transplant. So that's why newborn screening is so important. The other way these kids come to diagnosis is family history. So if you have an affected sibling, then with the subsequent pregnancies, people can be screened for the condition. Um, but that's why newborn test screening is so important. So this is what I talked about. So this is for Krabbe disease. The blue states are the ones that are currently screening. Here is Illinois. Iowa's in the midst of getting it approved. And then what these peach states are, including Arizona, are they have legislation where they have policies for RUSP alignment. So once something is added to the RUSP, they have legislation in place that it's supposed to be added to the state. Now, what that means, how long it is until they add it, each state is different. And then, like I said, there's some changes in the political landscape that might change some of this and rolling out of this newborn screening. But this is a lot of the country. If this, particularly getting Texas, Florida, California, Arizona, it's a good majority of kids are captured. So, Krabbe disease has been a little challenging in the newborn screening space. We are very, very good at identifying babies with early infantile Krabbe disease. They have the first tier is GAL-C enzyme activity, and then most states have second tier testing for cytosine. And there's set ranges for cytosine that is very good at identifying those who have early infantile Krabbe disease. We also have gotten better over the years at identifying unaffected individuals, people with pseudo deficiencies that we cannot report out the results and not scare the parents and just dismiss these kids. What we've identified in newborn screening is a lot of these kids in this middle category. So kids that are at risk for late onset Krabbe disease. So these are kids who are at risk for having onset of disease later, and this means after the infantile. And of those, there's kind of two sets of kids. There are those who are at high risk for developing it earlier, like in a year or two of life, that we should identify and potentially transplant. And then there's those that are low risk for early childhood leukodystrophy, and those might have it in adolescents or adults, and those we can kind of be more reassuring or follow them slow, like we can follow them less closely because their disease will progress more slowly. It's important to note that for the RUSP, for newborn screening, the RUSP decided that the goal of newborn screening was only to identify those with early infantile Krabbe disease. So it is, but there are some people kind of on the national stage who feel like that's unethical to not also disclose results or find these kids are at high risk for disease within a year or two of life. So it's just going to be important if and when newborn screening rolls out to know what the state looks for, where the cutoffs are, because there are kids that may be missed. You will not miss the early infantile kids, but we may miss kids that would present in early childhood that still would have rapidly progressive disease that would benefit from stem cell transplant. And then for stem cell transplant, it's the only clinically available treatment to alter the natural history. It must occur prior to symptom onset. So and the studies show it needs to be done probably within about the first 30 days of life. And so positive newborn screening requires immediate action to get these kids evaluated and ready to go. And then, as you know, this allogenic stem cell transplant requires myeloablative chemotherapy, and then you get stem cells typically sourced from umbilical cord for these babies. So we're in the process of publishing a paper looking with guidelines for when a baby screens positive for infantile Krabbe disease, kind of how to work them up and how to get them quickly to transplant. And so the recommendations are ahead of your first positive case to have a pre-assembled multidisciplinary team able to coordinate it. So a lot of newborn state screens report out their results to geneticists. So, the geneticists are critically important for diagnosis and confirmation. Obviously, the neurologists play an important role in assessment and workup and follow-up. And then you really need to have a transplant team in place for donor identification, pre-transplant workup, and then transplant. And then, like I said, depending upon the cutoffs, newborn screening may or may not identify those who are at risk for later onset forms. And of those, a small subset of them will present early, like 1 to 3 years of age, and still be candidates for stem cell transplant. I'm not going to get into too much of the nuances of this, but let me just say one sentence that stem cell transplant is a super big deal. And it modifies the disease course, but is not curative. It does a better job with the central nervous system disease. It does not do much for the comorbid peripheral nerve disease. And so there are some families, very thoughtful, caring families, who stem cell transplant would not align with the goals of care for their baby. And so we have had people who have who have chosen not to proceed with stem cell transplant after we've reviewed what it would entail. So this is just kind of a transplant timeline. And what's important to note is that newborn screening is 24 to 48 hours. There's publications to say that urgent newborn results should result by 5 days of life. I think that's pretty ambitious, but hopefully, soon after you'll get these results, immediately refer them to a center and start the process. And then our goal is to get them transplanted by 30 days of life. What is unusual about Krabbe disease is the stem cell transplant consensus and national experts recommend beginning chemotherapy before you have that stem cell bag in hand, which makes a lot of people nervous, but one will not make it to that cutoff if you don't start chemotherapy before you actually have your cord blood. And typically cord blood, the match doesn't need to be as close. There's more units. It is safer to begin chemotherapy even if you don't have the cord blood in hand. And this is our center participated in evaluation. This was 6 children that were identified so newborn screening was initially started in New York and then rolled out. So this is a study that our site was one of the studies looking at newborn screening in looking at stem cell transplant outcomes and those that were identified via newborn screening. And the important points are overall survival. So all of these children at 5 years of age were still alive, which is in stark contrast to the natural history of Krabbe disease. The other thing to note, so these are the Bayley scales of infant development. So, 100 being average, these are language and cognition scores that are in the lower range. And then the motor is still more severely affected. So these children, all of these had greater than 1 standard deviation below the mean, but considerably better. I mean, these are kids that are talking in sentences and crawling around, able to walk with assistance. And so that is very different than the natural history of Krabbe disease. The other thing that's important to note is that these were the 6 kids that were in states, including Duke, that's pretty aggressive in stem cell transplant. And here is like 30 days. Only 2 of them made it to that 30-day benchmark. So the benchmark was transplant before 30 days of life. And I think only 1 of them made it. So that's pretty ambitious and takes a lot of coordinated effort. Okay, so let's pivot a little bit to talk about metachromatic leukodystrophy, and I'm trying to be cognizant of the time here. So, this is an an autosomal recessive condition caused by the deficiency of aryl sulfatase. We'll talk about a new treatment, a new FDA-approved treatment for MLD, and so it's important to differentiate what the age of onset is. So there's kind of same with this condition. There's different. So there's late infantile where they have that's the most common form. So the most typical presentation is late infantile where they present less than 2.5 years of age. Then there's the juvenile form where it's in between, and then there's the adult onset that's greater than 18 years of age. For the juvenile, they've also kind of um, they kind of fall out in two big categories. One is early juvenile MLD, where they present between 2.5 and 7 years of age. And then there's late juvenile, which presents between 7 and 16. The reason this is important, and this seems a little trivial, but the reason this is important is because of treatment. So the late infantile and the early juvenile together are considered early onset MLD and are eligible for treatment. And we'll talk about treatment. So, but in states, which is pretty much all of them, where there is no newborn screening, typically these kids come to medical attention, the earlier forms, too late for curative therapy. So they have early typical development, then have stagnation of motor development. We see with the kids with late infantile, they're kind of persistently clumsy toddlers. Maybe they walk or sort of pull to stand around 14, 16 months of age, and then just kind of never get the hang of walking. Um, and then they have regression, new problems in speech, behavior, balance, coordination, and then they often have a peripheral neuropathy with it. Um, that is a clue. So if you see a kid who obviously usually when they have spasticity and clonus, you expect them to have hyperreflexia. So one clue to MLD is that they can drop their reflexes. Although I've also been burned assuming it wasn't MLD because they still had brisk reflexes. So I think that it's helpful if they're absent, but certainly they can still be present. And then diagnostic features, it's absence of the aryl sulfatase, and then you send the urine sulfatides. The MRI brain shows this T2 flare hyperintensity that's subcortical, more posterior. And then you can see that it's bright here, and you can see a little bit that it's dark here on the T1 imaged. These kids have elevated protein as well, and then decreased nerve conduction velocities. We've had several kids at our center with late infantile. They are cognitively intact. They have progressive weakness and hyporeflexia, and very well-meaning, appropriate pediatricians send them to our neuromuscular specialist. And our neuromuscular specialists do nerve conduction studies and find that they have demyelination consistent with MLD, and then get the MRI brain. So we've had several kids come to diagnosis that way. So these cases can be tricky when they're little. And then later, the children become non-ambulatory with spastic quadriplegia, feeding difficulties, optic atrophy, and then and typically, as we know, the younger they present, the faster it progresses. So these kids with late infantile may die in the first year or so after diagnosis. And then the kids with juvenile can live longer, 5, 10 years with their condition. So the proposed newborn screening for MLD will be first the elevated sulfatide and the dried blood spots, and then the secondary test will be the ARSA-A activity, and those will be considered screen positives, and then the genetic testing will be third tier. Fortunately, there's been some pilot studies in Europe, and I think New York had a pilot study too. Fortunately, the phenotype, genotype, and test results for MLD is tighter than Krabbe disease. So I think people are pretty hopeful that when they get these newborn screen results, they'll be able to easily put them into these categories of presymptomatic involvement. But we know that this might be trickier than anticipated. And so this is really a breakthrough therapy. This is this adadarsigine automacel, ARSA-C. It's a one-time individualized single dose infusion made from the patient's own hematopoietic stem cells that have been modified to have the ARSA gene. And so the phase 1 to 2 trial showed benefit. And so it was actually FDA approved in March of 2024. And this is recently, a couple months ago, the New England Journal of Medicine article about kind of long-term follow-up. And I'll show you the next slide. It's amazing. As you can see, the cost of this medication is a lot. $4.25 million is the most expensive medication that has been approved, the highest price tag on any medication thus far. And this is not available everywhere. So there's treatment centers across the country that are able to provide this. So basically, in the United States, it's Lenmeldy in the United States, Libmeldy in Europe, and it's approved for 3 categories of kids: pre-symptomatic late infantile, pre-symptomatic early juvenile, or early symptomatic early juvenile. And that's going to be a little tricky. What does early symptomatic mean? I think the cutoff for the clinical trial was like an IQ of 100. So, or maybe it was 80. Oh, I can't remember. I'll have to look at the paper. But so they do have MRI involvement already and clinical symptoms already. So that is going to be a point of nuance as far as if people present symptomatically. So once you've confirmed the diagnosis, you refer them to a center. They do blood cell collection. They select the CD34 cells, do ex vivo transduction with the lentiviral vector, put the gene in, send it back to the center, and infuse it. This is the New England Journal of Medicine publication, and this is for severe motor impairment, and overall survival. And the peach orange lines are ARSA cell treated, and the others are the natural history trials untreated. So basically, the gist of this entire thing is, oh my goodness, people look way better. And then this is like the younger kids, and this is the older kids. So, I mean, these Kaplan-Meier curves just look amazing. Everyone looks so much better with the treatment. And like for overall survival for the late infantile, I mean, it's just incredible. Okay, so I'm getting a little short on time, so I want to make sure I can go over all this. So the other thing that's in the newborn state screen is X-linked ALD. And so this is an accumulation of very long chain fatty acids and breakdown of the myelin. The tricky thing with X-linked ALD is that there is not a lot of phenotypic genotype correlation. So within a family of 2 affected brothers, one can have the catastrophic childhood form and another one can have adult onset AMN. So these kids need to be followed over time. There is no way to predict who is going to be that third of kids who have the catastrophic cerebral form that is amenable to treatment. So the childhood form presents in boys. So the childhood cerebral form presents in boys, change in behavior, decline in school performance, and then it can be rapidly progressive. They have a posterior predominance of T2 flare hyperintensities. And what is unique about X-linked ALD is this leading edge enhancement. They also have adrenal insufficiency, which is one of the reasons it was added to the newborn screen. Because you cannot predict who is going to have this catastrophic form, there is published criteria for screening them with MRI scans before symptoms. We know that typically in the MRI, it starts here in the corpus callosum, and usually there's about a year lead time between when the MRI changes and there's contrast enhancement. So it's important to follow them over time. We typically recommend a baseline MRI scan just to make sure they don't have a perinatal process or congenital brain malformation that later you'll have trouble knowing what's what. And then between 3 to 12 years of age, they need MRIs every 6 months to assess for pre-symptomatic disease. Um, I'm gonna go through this a little bit quickly so we have enough time for questions, but there also is a autologous stem cell therapy for X-linked ALD. So it's the same thing as the MLD. They mobilize your own stem cells, genetically modify them to have a functional copy of the ABCD1 gene, and then give them back. This was approved in September 2024. It's relatively a bargain at only $3 million. And it's a one-time treatment given via IV. The problem that has emerged with this therapy is that some of these treated kids have had secondary malignancies and myelodysplastic syndromes, including um, AML. So this is only indicated for boys with active, so enhancement, cerebral ALD, if they do not have a matched donor. So for those with a matched donor, it is still safer and recommended to do the traditional um, um, allogenic stem cell transplant. And then there's some other things in the pipeline. So CTX is important to diagnose because there's an FDA approved treatment in adults. It is maybe being used off label for children, but it is approved for use in adults. And then same with the Cardi-Gutierrez syndrome, JAK inhibitors, including baricitinib. The clinical trial is promising, but for some reason it still is not FDA approved for that indication. And then there's clinical trials for Alexander, for Canavan, and vanishing white matter disease. So this is an exciting time. Um, so just to kind of, this is so exciting that there's all these potentially life-saving treatments, but just also it's so important to treat the whole patient. And even in the absence of curative therapies, we have lots and lots of things we can offer families. I think people used to hear the message, you know, your child has a serious condition, take them home, love them, and watch them die. And that is just not, you know, we all are dying. Like we are all going to die. We need to provide the best quality of life and care throughout the course of their illness. So we published this paper about practical approaches and care for the kids with leukodystrophy, including sleep disturbances, pain, seizures, cognitive and developmental difficulties. Palliative care is so important. Anyone with a longitudinal serious condition um, needs a palliative care team to follow them longitudinally and help with complex medical decision making. And that's my soapbox. I have additional palliative care training, and I try to get them to see them early outpatient to kind of establish the importance of longitudinal care. So in summary, leukodystrophies are inherited disorders affecting the white matter of the central nervous system. Individually, they're rare, but collectively, they're common, more common, and demand attention and research support. They should be suspected in any infant or child with motor arrest and regression, particularly with spasticity and ataxia. The adult onset leukodystrophies can have more neuropsychiatric symptoms, so you need to have a high index of suspicion. The diagnostic evaluation includes an MRI brain and then enzyme and genetic testing. And then curative therapies are stem cell transplant with or without gene therapy for early or pre-symptomatic individuals. And we always look at clinicaltrials.gov to look and see what's open. And then symptomatic and supportive therapies are critically important, as is obviously supporting families. So just to give you an idea of like what our clinic looks like, it's a multidisciplinary clinic twice a month, a full day, and we have geneticists, genetic counselors, myself, an endocrinologist who sees the kids with X-linked ALD. Some of the other ones have endocrinopathies with them, like Zellweger's. We have a nurse care coordinator, social work, palliative care, and we actually now added a physiatrist for half a clinic from our rehab center that comes and assesses all their physical rehab needs too. It's been amazing. it's a long day for families, but hopefully they get everything they need while they're there and some snacks. So these are some references. If you find them helpful, I can share some of this afterwards too. Okay, thanks. That was a lot of information. So let me pause and see what questions you guys have.
Thank you, Dr. Rubin. That was an incredible talk and very helpful, especially to review, the newer therapies that are coming down the pipeline. A couple of things. So, Dr. Kaur, who is one of our geneticists here at Phoenix Children, said we are starting Krabbe's next year in Arizona, which is awesome to hear. Dr. Vinod Narayanan asks, have you used metabolomic screening tools like global maps from Baylor?
Um, I don't know the answer to that. So I think that so I didn't talk a lot about undiagnosed leukodystrophies. So, typically we do whole exome sequencing. And then if it's an undiagnosed leukodystrophy, there are some other avenues we have to explore. Um, was there something specific you had in mind?
If you're there, Dr. Narayanan, I'm not sure if you had a follow-up to Dr.
And then
Rubin's. Oh, in place of the mini metabolic screens.
right,
Okay,
right. Yeah, yeah. I
okay.
think we just usually have it's so hard. It's so hard to get send out labs and to train this faculty and everyone to get the right amount. So right now, that's what we're doing, but I think it'll be interesting to see if things change over time. And then as far as newborn screening goes for the state, just to kind of put a plug into, they have monthly Private Council meetings. So if you get cases that are in that intermediate zone where they're not, obviously the infantile is urgent and those are pretty easy to tell. But if you have these intermediate cases, we have a monthly council meeting where people bring their genetic test results and enzyme testing, and we kind of make recommendations how often to do screening and follow up for those patients over time. So just a plug for that too.
I have a question in regards to kind of the sleep disturbances that you can see with these leukodystrophies. And, we're thankful to have Dr. Hopkins, also our sleep medicine specialist in neurology. And just wondering, do the sleep disturbances for individuals with leukodystrophies kind of come in all different flavors? And then, what's kind of your approach to screening for those in terms of when you might pull the trigger on a sleep study? And then just from management, medication wise, are there things in particular that you have found helpful?
Yeah, so I think, what one of the nice things about having a multidisciplinary team is, if one of us has forgotten to ask, sometimes the other specialties do. So I think rehab is really good about asking about sleep too. And I think it's multifactorial. I think that sometimes it's related to discomfort or spasticity. Sometimes it's related to feeding intolerance. One of the things we see in a lot of these kids who end up having a lot of oropharyngeal dysphagia and get G tubes is that the baseline metabolic demand for these kids who are non-ambulatory is not the same. And a lot of these kids are getting overfed and have a lot of GI discomfort and reflux and feeding intolerance. So, that would be a good screening. Are you feeding overnight? Do you have overnight feeds going? Is it positional? So I think some of those kind of, when we were tasked with creating these practice parameters or guidelines for managing symptoms in leukodystrophy, the leukodystrophy community really wanted it. But I think these are the same things we use in a lot of our kids, even with severe neurologic impairment, even if they have static conditions. So it's kind of the same thing. Is their tone well managed? Are their feedings okay? Is there symptoms of obstruction or obstructive sleep apnea? If there's symptoms of, that's when I would pursue a sleep study. or looking to see if there's seizures. And then I think it's important to use the side effects of the medications to your advantage. So if the child is having spasticity, and they're having trouble sleeping, then I might give a higher dose of baclofen at night to help with sleep, or clonidine that would help with sleep and discomfort. Or give an anti-epileptic medication like Onfi with a higher, if they have seizures, then give the higher dose at night to help with sleep. So I think some of those things are kind of what we all do with kids with severe neurologic impairment. And it isn't necessarily unique to leukodystrophies.
Thank you. Any other questions?
Hi, Jen. It's Kara again. Nice to see you. That was great. Really, really, you know, um, well, it just reached all the different areas that we need to do in a short period of time, which is hard to do, I know, and that kind of thing. And I'm glad to hear how your systems do it, and how, we're going to need to be doing this too, since we're going to be doing Crab next year. My one question for you is something that I just learned this year, that we have a lot of people, obviously, who decline immunizations. That's been going on forever. We know about people who could decline immunizations, um, or vitamin K or things like that. But I just learned this year that we have people who are declining newborn screening. And I didn't know that was even a possibility, or even something there. And I don't know how widespread that is, if that's an Arizona thing, or if they're finding people who are doing that. And you can't really approach it differently, because if they then show up to have the condition, then they've no longer been screened. But I don't know if you have anything to say about how common that is where you are.
Um, uh, most of the Um, most of the newborn screening is opt out. So I think the threshold, instead of like vaccinations where you have to consent for them, I think a lot of states have an opt out for newborn screening. So I think the bar for families declining it is higher. And so we have not had a lot of that. Um, I think that it's tricky. I think that families do not understand what all these tests are. And I do think it's stressful for families to get these newborn screening results that haven't been adequately explained to them or scared them. There have been studies to show, like, for example, in cystic fibrosis, that even identifying a risk for a condition, coming back and being told your child does not have that condition, there's like this vulnerable child, and even years later they're sort of carry a little trauma from being worried that their child has this serious condition. So I do think we need to be thoughtful about explaining newborn screening results. But when you look at parity and level playing field for access to therapies, newborn screening is it. I mean, you really, now maybe there isn't the same access to travel to centers across the country, or access to afford a $4 million therapy, but it is a first opportunity to level the playing field, to screen everyone so that we identify those regardless of race, socioeconomic status, location, to identify everyone that's at risk for a condition. So, yes, I hope that it does not become trendy to decline newborn screening.
Thank you. Same here.
Well, thank you again, Dr. Rubin. We
Yeah, thank
appreciate it,
you.
and looking forward to seeing you at the next conference somewhere. So,
Yes. And then, we are a small group of very dorky individuals. So once your newborn screening starts rolling out, or ahead of it, like I said, we're going to put out guidelines. They're going to be submitted for publication soon to
okay.
help centers do that infantile Krabbe plan, like a blueprint for how to do that. And then, there are people across the country that are, our colleague, um, Joanne Kurtzberg and Duke. I mean, there's people that literally are willing to give their cell phone out
Okay.
to have these newborn screening results.
Wonderful.
Okay.
Wonderful.
Yeah.
I'm sure we
Yeah.
will be in touch for sure.
Yes. Thank you.
Well,
Have a great
thank
rest of your
you.
day.
You too. Bye.
Bye.